Now see, Cashman's bursa is like swollen subcutaneous infrapatellar bursa in persons during praying in kneel down position with trunk upright. Okay. Then, so now the other bursae what we have is between medial head of gastrocnemius and capsule. We have Brody's bursa. All these bursae are important because bursae itself can be a short note. Bursae around the knee joint. Okay, between the gyrobes. On the medial side of the tibia, we have the insertion of the posterior compartment of thigh muscles. Like basically, all the three compartment muscles will get inserted on the upper end of the tibia. On the medial aspect of the upper end of the tibia, we have sartorius coming from anterior compartment, gracilis coming from medial compartment, and semitendinosus coming from posterior compartment. They are actually called as gyrobes, and between them also there is one bursa which is called as anserine bursa. In order to prevent friction, we have this bursa. Okay. So we also have a bursa between superficial and deep part of tibial collateral ligament. Okay, between semi-membranosus and medial condyle of tibia. Okay. Then there is a condition which is called as Baker's cyst. That is, at the back of the knee joint, there will be a swelling. Chronic inflammation of bursa deep to semi-membranosus. Okay, deep to semi-membranosus, you will see there will be a cystic swelling. This we have also, I told you this when we were discussing popliteal fossa also. This is called as Baker's cyst. Okay, so on the posterior aspect. So now coming to the blood supply of the knee joint. Blood supply of the knee joint is, we have studied the branches of popliteal artery when we were doing popliteal fossa. You give the same names without any doubt. Genicular means they are going and supplying the joint. So we have superior medial genicular, superior lateral genicular, inferior medial genicular, inferior lateral genicular, middle genicular. Okay, so apart from that, we have descending genicular artery coming as a branch from femoral artery. We have one recurrent branch coming from anterior tibial artery. So all these are the branches which are supplying the knee joint. Coming to the nerve supply, so we have femoral nerve, which is the nerve of anterior compartment, obturator nerve, which is the nerve of posterior compartment. We know sciatic nerve is dividing into two nerves. This is the sciatic, which divides into tibial and common peroneal. So all nerves you have to write for knee joint. Okay. Now what are the various movements we have? Flexion, which is permitted 122, like this one, like 150 degrees. This is brought about by biceps femoris, semitendinosus, semimembranosus, gracilis, sartorius, and popliteus. Extension, we have like this movement is extension, like while we walk. So this is brought about by quadriceps femoris, front of the thigh muscles. External rotation, something like this. So that is biceps femoris 30 to 40 degrees is permitted. Internal rotation, when you take it inside little like this, we have sartorius, gracilis, semitendinosus, popliteus, and semimembranosus. So movement and muscles bringing about the movement are also important. Okay. These are all complicated things but are not required. Why I don't want to trouble you. Applied, like we have Genoverum and Genovalgum. I'll show you, like if the so I'll take some other pictures. See, Genoverum is, if you see, like if something like knock knees, like if there is outward projection of the knee joint, you see this particular angle is increasing, you call that condition as Genoverum. Okay, and if it is moving, if knee joint is moved inwards, you call it as Genovalgum. Okay, these are the two bony deformities which are basically related with vitamin D deficiency also, calcium deficiency also. Okay, sometimes there may be patellar dislocation, okay, as one of the applied aspects. So if the person is falling because of some accident, you may see like the fracture of patella may be there. It may be undisplaced or it may be transverse. If it is in many pieces, you call it as comminuted. Okay, different types of fractures we are seeing better. Okay. So patellofemoral syndrome, pain deep to the patella, often results from excessive running, especially downhill. So that's what is only one point you can write. Then osteoarthritis is the commonest condition which we usually see with old people. So degenerative wear and tear articular cartilage. That means this is the hyaline cartilage. Okay, out of old age, this hyaline cartilage got degenerated, so they will have difficulty in walking. They will have pain in the knee joint, especially. Okay, because it is weight bearing joint. Then movements may be painful, limited, and they produce grating sound. Okay, so that is osteoarthritis. Meniscal tears, I will show you. Like we know, like this is, we have medial meniscus, lateral meniscus. Sometimes because of the accidents you find, these menisci may be torn. Okay, we know we have anterior and posterior cruciate ligaments, so they may also get injured in athletes when they are moving the knee joint in abnormally, like exaggerated directions. Okay, so anterior cruciate ligament is more commonly damaged, and it is seen in anterior dislocation of tibia. Okay, like that. So you are finding this is anterior cruciate ligament. This is normal, and you can see it is torn now. Okay. So similarly, posterior cruciate ligament also may be torn if there is any injury. So aspiration of knee joint generally we do when we are suspecting some pathology. Some cancer, if you are suspecting with knee joint, we generally collect the synovial fluid here to check if any cancer cells are shed here. And sometimes we use this procedure to give some drugs also, especially in case of osteoarthritis, in order to inject like uh, like synovial fluid type of injection, which will give lubrication. Okay, arthroscopy is a technique where you will see the interior of knee joint. Okay, knee replacement surgeries are quite famous with orthopedicians, where we are putting the artificial transplants in the area which got degenerated. Okay, the articular cartilage of the lower end of the femur and superior aspect of the tibia, they are replaced by artificial things. Okay, that is generally plastic tibial component is there. Okay, steel component is also there. These are all prosthetic devices which are used. Okay, so unhappy triad of knee joint. Sometimes this may be asked, but if the question is complicated, paper is complicated. So what is this unhappy triad of knee joint? So combination of injury of tibial collateral ligament, all medial side. Tibial collateral ligament, medial meniscus, and anterior cruciate ligament. Okay, MAT, 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 some code you keep, you will remember easily. Medial meniscus, anterior cruciate ligament, and tibial collateral ligament. If they get injured, you call it as unhappy triad. So that finishes knee joint. So in order to understand sciatic nerve, we should know sacral plexus. Okay. So in the sacral plexus, what are we finding? See, these are the lumbar vertebrae, and this is sacrum bone. So now you are finding in from the sacral foramina, you are finding S1, S2, S3, S4, S5 nerves are coming out, and they form a network. This network helps in the formation of sciatic nerve. So this sacral plexus, actually how is it formed? By anterior rami. That means when you see in front, you call them as whether ventral or anterior rami. L4, L5 also we are seeing, this is L4, L5, then S1, S2, S3 and S4. Most of them, they are just joining in front of the piriformis muscle to form sacral plexus. Okay. Now, now, if you just look at the sacral plexus, what are the root values we have? L4, L5, S1, S2, S3 and S4. So, if you see L5, S1 and S2, S3, we are finding there is one yellow component which are dorsal divisions. You are finding pink components which are ventral divisions. They are joining to form sciatic nerve. Okay, don't read all of these things. So you will see sacral plexus main nerve is sciatic nerve, which is going and supplying the lower limb. Okay, now sciatic nerve, it is coming from sacral plexus. Root values L4, L5, S1, S2 and S3. This is the largest branch of the sacral plexus. Okay, the sciatic nerve. And this is the largest and thickest nerve of our body also. Sciatic nerve. Now, when we see this picture, you don't read anything. I'll try to make you understand from here. This is actually gluteal region. In the gluteal region, the first muscle we have is gluteus maximus. Below gluteus maximus, we have structures under the cover of gluteus maximus like gluteus medius, minimus, piriformis. So piriformis is actually called as key muscle because below piriformis you are finding sciatic nerve is coming out. It has formed in the pelvic cavity that is in front of the piriformis muscle, and now it is coming behind. Okay, it is entering into the gluteal region, buttock region, and then it is entering into the posterior aspect of the thigh. Okay, so it is running below piriformis. It runs over obturator internus, superior and inferior gemellus muscle. It runs over quadratus femoris, and then it is running on the posterior compartment muscles. So you should now remember the muscles of posterior compartment. I am naming them. We have semi-membranosus, okay, semi-membranosus, semi-tendinosus, biceps femoris, which has short head and long head, biceps femoris, and adductor magnus, which is also seen in posterior compartment. Why we should remember these four names? Because sciatic nerve, when it is entering into the posterior compartment of the thigh, it supplies these four muscles. I'm naming once again. We have semi-membranosus, semi-tendinosus, biceps femoris, and adductor magnus. These are the four muscles which are supplied by sciatic nerve. And we know pretty well because we finished popliteal fossa. If you are concentrating, sciatic nerve is dividing into two terminal branches in the popliteal fossa. This is back of the knee joint, which is popliteal fossa. You can see the two terminal divisions of sciatic nerve. Medially, you have tibial nerve. Laterally, we have common peroneal nerve. Okay, if you understand this diagram, understanding this is very easy. See, sciatic nerve lifts the pelvis through greater sciatic foramen. It is running below piriformis muscle. It passes in the gluteal region between the ischial tuberosity and greater trochanter. This is ischial tuberosity, this is greater trochanter. In between them, it is entering into the posterior compartment of the thigh. Terminal divisions are tibial and common peroneal nerve. Okay, then see, this is popliteal fossa, which we already finished. So you can see it is dividing into tibial and common peroneal. So branches of sciatic nerve, it gives muscular branches to hamstring muscles. What are hamstrings? Posterior compartment of the thigh muscles are called as hamstrings. Okay, we have flexors of knee, extensors of hip, all muscles below the knee. Then we have common peroneal, which is one of the terminal divisions. No, so many times I told you common peroneal is dividing into superficial and deep peroneals. Superficial will go and supply lateral compartment, and deep peroneal supplies the anterior compartment of the leg. So you can see the course now. This is whole thing is sciatic nerve, this is popliteal fossa, this is tibial nerve which supplies the posterior compartment of the leg. This is common peroneal nerve which is going on the lateral aspect, okay, of the leg. So muscles of the anterior and lateral compartment of the leg are supplied by common peroneal. Muscles of the posterior compartment of the leg and intrinsic muscles of the sole, they are supplied by tibial nerve. Okay. Then let us see the branches of sciatic nerve. It gives cutaneous branches to all leg and foot. Okay. So like you have this is one of the cutaneous branches which you are seeing, except the area supplied by saphenous nerve. So which is the saphenous nerve here? See, saphenous nerve is shown in this color. Okay, so except for saphenous, whatever area you are finding, they are indirectly supplied by sciatic nerve. That means, see, common peroneal nerve is one of the terminal branches of sciatic nerve. Common peroneal nerve, all these are the names what we see with the terminal branches of sciatic nerve. Okay, so it is supplying to almost all parts of the leg. Okay, so and foot. Then so now we are also discussing the other nerves which are actually because as a part. So anyhow, somewhere it will come now. So let me finish tibial nerve. So one of the terminal divisions of the sciatic nerve is tibial nerve, which is going into the posterior compartment of the leg. Now you should know the muscles of the posterior compartment of the leg. From popliteal fossa, you have seen these two muscles. What are those? Medial and lateral head of gastrocnemius. We have seen below gastrocnemius, we have seen soleus, we have seen plantaris. The other muscles we see are Tom, Dick, Harry. Like that you remember. We have tibialis posterior. Then we have flexor digitorum longus. Then flexor hallucis longus. Okay, T, tibialis. Tom, Dick, flexor digitorum longus. Harry, flexor hallucis longus. So these are the muscles over which tibial nerve is running. So it passes below flexor retinaculum, okay, this tibial nerve, and then it is entering into sole. Once it enters into the sole, this tibial nerve divides into two. One is medial plantar nerve and the other is lateral plantar nerve. Okay, so tibial nerve descends through the popliteal fossa. It is entering into the posterior compartment of the leg. It is accompanied by posterior tibial vessels, which are the terminal branches of popliteal artery, passes behind the medial malleolus to reach the sole of the foot. In the sole, it is dividing into medial plantar nerve and lateral plantar nerve. This is the way it is entering into the sole. This is the course in the sole. Okay. So common peroneal nerve I have discussed already as one separate lecture, in fact. Now causes of sciatic nerve injury. See, the sciatic nerve is most frequently injured when badly placed intramuscular injection in gluteal region. See, in the gluteal region, we have to choose outer and upper quadrant. When I show you the gluteal muscles, there I will show you. Basically, in the gluteal region, we have four quadrants. We have to choose the upper and outer quadrant to give intramuscular injections. If we choose any other quadrant, the risk of damaging this nerve becomes more. Okay, so upper outer quadrant of buttock we have to choose to avoid injury to the gluteal nerve. Sorry, to avoid injury to the sciatic nerve. Then, what are the other things which we see? The most nerve lesions are incomplete, and in 90% of injuries, see in road traffic accidents, when you are finding this type of injuries there, you will see sciatic nerve is damaged. Okay, so suppose if knee area is involved, you will see common peroneal nerve may be damaged. Okay, so sciatic nerve, suppose if it is injured, what are the muscles which are supplied by sciatic nerve? Posterior compartment of the thigh muscle. So that action will be lost. So marked wasting of muscles below the knee, you will see weak flexion of knee. Sartorius and gracilis are intact because they are supplied by the femoral nerve, sartorius and gracilis. Extension of hip is like also becomes weak. Gluteus maximus is intact because it is supplied by inferior gluteal nerve, not from sciatic nerve. All the muscles below knee are paralyzed, and weight of the foot causes it to assume plantar flexed position, which is called as foot drop. I told you this foot drop when I was doing common peroneal nerve. At the neck of the fibula, if there is any injury, you call that condition as foot drop. Okay, and person will be having difficulty in walking. We should have seen people with polio also walk with difficulty with something like injury of this. You call that gait, manner of walking as stamping gait. Okay. So these are the sensory areas which are supplied by sciatic nerve and its terminal divisions. And sensory lesion. So sensation is lost below the knee, okay, except for the narrow area which where saphenous nerve is supplying, that area is spared. Okay. So sciatica, you should have seen most of the old people or obese people, they will be complaining like they will have pain along the posterior aspect of the thigh, and pain is radiating on the posterior compartment of the leg and it is going up to the sole. Okay, that condition is actually called as sciatica. Pain from sciatica radiates from buttock down to the leg and it can travel as far as feet and toes. Okay, this is due to compression of sciatic nerve. Okay, that is sciatica. So in patient sensory distribution, this pain is experienced in posterior aspect of the thigh. The same thing is written here. So sciatic nerve may be compressed due to many reasons. Like it may be one of the reasons is prolapse of intervertebral disc. Okay, so which we can how can be diagnosed by making certain MRI X-rays. Okay, so you will see a lot of pain along the distribution. Sometimes sciatic nerve may be inflamed also. Okay, at its terminal branches. This is the typical picture where you are finding inflammation. Okay. Common peroneal nerve and tibial nerve injuries. Common peroneal nerve is foot drop. Okay, tibial nerve is supplying which compartment? Posterior compartment. So obviously, if tibial nerve is damaged, you will see all the muscles of the back of the leg and sole of the foot are paralyzed. Okay, so you will see the opposing muscles, dorsiflexors of the foot. This typical position you will see in case of tibial nerve injury. Okay, so this is called as talipus calcaneo valgus. Okay, so it looks like this. So that is all about sciatic nerve. So what are the other questions we had, Beto? Keep reading sciatic nerve till I take you to the next answer. So this is appendix. See, you are finding this is the large intestine where we have ascending colon, transverse colon, descending colon, sigmoid colon, rectum, anal canal. So in the ascending colon, the first part what we have is cecum. From the cecum, whatever area we have, that is appendix. Okay. So now let me take you to, this is all about large intestine, cecum. So cecum, where is it situated? It is situated in right iliac fossa. We have 9 regions in the abdomen. So one of the 9 region you have is the right iliac fossa, isn't it? The length of cecum is 6 centimeters and breadth is more. That is 7.5 centimeters. It is asymmetrical. Okay. So this is cecum which we see in the right iliac fossa. 6 centimeters in length, 7.5 centimeters in width. Now we have different shapes of the ceca. Like we have fetal type, which is 2%, which is conical and appendix is arising from its apex. Infantile type, which is 3%, it looks like a quadrate shape and appendix is arising from its depressed bottom. This is appendix. This is normal adult like 90% of the ceca look like this, which is right saccule is big, left saccule is small, exaggerated where right saccule becomes hugely enlarged. Okay, now coming to the position, normally you see cecum is present in the right iliac fossa, but due to faulty rotation of gut, we have some abnormal positions also. Instead, cecum appendix in right area, we may find in the left area. Sometimes cecum appendix may be seen in the umbilical region, it may be seen below the liver, it may be seen in the right lumbar region or pouch of Douglas. Now, peritoneal relation. Cecum is covered by peritoneum on all the sides. Okay. So, 5% cases, upper part of its posterior surface is non-peritoneal. You can skip all these exceptions, because cecum is completely covered by peritoneum. Now, we have to check the relations front, behind, above, below, medially. Okay. Now, suppose this is the cecum, what you are finding in front. So, anteriorly, we have anterior abdominal wall, lower margin of greater omentum and coils of ileum. Those are anterior relations. When you lift the cecum posteriorly, we will have right iliopsoas muscle covered by fascia iliaca. Here in this area, we have lateral femoral cutaneous nerve, trunk of femoral nerve, genitofemoral nerve and retrocecal recess. Okay, then this is cecum and above it is related to ascending colon. Only one point you can write. Below it is actually resting on inguinal ligament, lateral half of inguinal ligament. So medially, what is opening in the cecum? This is cecum and this is ileum. Ileum is the last part of small intestine. I told you DJI, duodenum, jejunum, ileum. Ileum is opening into the cecum. So medially you are finding the terminal part of the ileum and it is guarded by a valve. Okay, the name of this valve is iliocecal valve. This is iliocecal valve. It has upper lip, it has lower lip and this area is called as frenulum. Okay, then now coming to the blood supply of cecum, the name of the blood vessels, cecal arteries, you can just remember. Cecum, cecal arteries, very simple. From anterior aspect, anterior cecal arteries. From posterior aspect, posterior cecal arteries. These cecal arteries are the branches of ileocholic arteries. Okay. Now, venous drainage of cecum, we have ileocholic vein, superior mesenteric vein, which drains into portal vein. Lymphatic drainage, it drains into ileocholic group of lymph nodes. Okay. Nerve supply, sympathetic superior mesenteric plexus, parasympathetic vagus. Now, when you just cut open the cecum, interior, what is this opening? I said that is the ileum is opening into the cecum, and this is the iliocecal valve. These are the lips, and this is the frenulum. Not only that, the interior of cecum is also showing the opening of appendix, appendicular orifice. Opening of appendix is seen, opening of ileum is also seen. Now, the interior of cecum, we have iliocecal orifice, which is situated posterior-medially. Okay, then it is guarded by a valve, that is upper lip and lower lip. The upper lip looks little horizontal and lower lip is concave. Both the lips are meeting at this point, which is frenulum. Okay, right side and left side, two lips, you call them as frenula. So each lip, this is upper lip and lower lip, they are actually formed by the folding of mucous membrane. You call it as reduplication. Okay, then so after this iliocecal orifice, all these are not required beta. Then we have appendicular orifice, which is very important. So small circular opening in the cecum is appendicular orifice. Okay, so this is also guarded by a valve. The name of the valve is valve of Gerlach. Okay, so this is semicircular fold, which is valve of Gerlach. It is just 2 centimeters below the iliocecal opening. Okay. So coming to the applied aspects of cecum, you can see like sometimes the coils of like ilium, they may get like if the muscle tone has reduced, they may just enter into the cecum. So this condition is called as intersusception. So many coils of ilium, they are just entering into the cecum. Okay, they are just entering with the force and they are getting coiled and they are staying here. You call it as intersusception. Okay, intestinal obstruction, you can see if there is any obstruction, the food will be retained there only, and you will see the intestines width will increase. Okay, now after we are done with cecum, we will do appendix. Cecum and appendix together can come as an essay, or they may come separately also as an essay. That's why I'm taking two topics. Now appendix, this is the appendix. Narrow earthworm like tubular diverticulum, which is coming from cecum. It arises from posterior medial wall of cecum 2 centimeters below iliocecal junction. This is iliocecal junction, and 2 centimeters below we have this appendix. Now see, appendix, you are finding actually a part of cecum where three tinea, this is not appendix. So appendix, you know, see here, like any other part of our body, we have peritoneal covering, no? So the peritoneal covering of the appendix is called mesoappendix. For ovary, we use the word mesovarium. But transverse colon, I said mesocolon. Isn't it like that? Meso word is usually used to represent peritoneal fold. So now appendix, you see, breadth is less and length is more. Okay, so that's why it is kinking, that means it is folding on itself and it looks like an earthworm. Okay, so there is a small like 3 marks question which is called as McBurney's point. I remember it was asked for your exam also. So McBurney was the person who described location and clinical features of appendicitis and importance of operative intervention. So McBurney's point is a point which we generally palpate to check if there is any appendicitis. Inflammation of appendix is called appendicitis. So how to trace this McBurney's point? So junction of medial 2/3 and lateral 1/3 of the line joining the anterior superior iliac spine to the umbilicus. This is anterior superior iliac spine and this is umbilicus. The junction of medial 2/3 and lateral 1/3, if you just put your fingers and palpate in the patient, and if the patient is kinking with pain, then you can examine, like then you can confirm this may be a case of appendicitis. This point is the point of maximum tenderness. Pain on touch is called tenderness. Okay, so this McBurney's point we check to rule out the pain of appendicitis. Okay, the size of appendix differs like 2 to 20 centimeters. The length increases in young adults and diminishes after mid-adult life. It doesn't have tinea, like these are the tinea, appendices, epiploica, and the structures what we see in large intestine we do not see in case of appendix. The presenting parts are, it has base, it has body, and then it has tip. Okay, the base